I want to thank you for coming. And first off, anyone that has a cell phone, if you could put it on mute or vibrate, we would appreciate it. And we have one of the co-owners getting more chairs. On your seats, a couple of things. Flyer with this month's specials. And on the back, we're having a workshop to make your own wicked cider. If you tried the fire cider, Melissa's going to be doing a workshop. You need to sign up because we're scheduling it. And you're going to go home with a big bottle of apples of the wicked cider, the fire type cider. And she's going to teach you how to make it so you can be making your own at home. So there's information on that. Also, we're starting on Tuesdays. We're going to have Tasting Tuesday. Every Tuesday from about 10 to 5, we're going to have different things sampled and tasted upstairs. And we gave you a schedule. And you guys got the preview. There were gummies made with elderberry syrup, especially for the children. And they're healthy gummies. And so those were today, and it's going to be on Tuesday the 5th, and we have the list there. John and Andy, two gentlemen back there, distinguished gentlemen. For those of you that don't know, they're now the current owners of Johnson Compounding and Wellness, and it's great working with them. They're going to carry on Steve and Diane's tradition. Most of you have seen the change here over probably almost 2 decades since we've been in this location. And now we have some young blood and we're firing up and we're going to just keep moving forward and getting bigger and better. John and Andy are extending 20% off on the health and wellness upstairs on everything in the front store after the talk tonight. And that's as a thank you for coming. And if you don't receive our newsletter, if you leave your email upstairs, we let you know what's on sale, what lectures are coming up, what tastings are coming up. And with that, I'd like to turn it over to Dr. Kaye. He'll do, I hope, an introduction of himself. But one of the things, we get a lot of calls, a lot of women and men are looking for hormone replacement. And they're tired of you're either behind door number 1, 2, or 3. You have to fit into one of those slots. And hormones are wonderful, but they can be dangerous. And the best way is to individualize and to give your body what you need today, not this package A, B, or C, and whichever one fits the closest. And with that, I'll turn it over to Dr. Kaye.
All right, thank you.
How's the temperature?
Good.
Okay.
So thanks to everyone for coming out. I know everyone has a lot to do. And I'm glad to be back giving this talk. I gave it, I think 2 years ago. And my goal in this talk is to just sort of be one-on-one. I'm not here to lecture at you. I want to hear your questions and respond to anything. If you have a question, probably someone else does too. So if you interrupt me, I'll stop and do my best to explain things. So I'll get started, and I'm going to focus my talk on something that I've been doing at my practice since 2009 to a great degree, which is the use of bioidentical hormone therapy for women and men. We also practice a whole variety of integrative and holistic medicine areas, and I'll talk a little bit about them briefly, but I'm going to focus on the HRT. Okay, so Optimal Wellness is the name of my practice, and I'll just tell you a little bit about us. We're in Woburn at the Trade Center building. We probably have about 800 or 900 patients now. And I'm the only physician. I have a few assistants, and we've been there since 2009. And we're not a franchise, we're a private practice. These are some of the things we treat. We do we treat a lot of patients with hormone imbalance, menopause, PMS, men with low testosterone, people with hypothyroidism. We run a good weight loss program. We are involved in autoimmune disease, irritable bowel, chronic fatigue, a whole number of things, sports nutrition. We work with conditions that are often seen in people who are requesting hormone therapy, including osteoporosis and cholesterol, heart disease, and so forth. We've even gotten into Lyme disease in the last couple of years. This is our website if you want to learn more about wellnessmd.com. And that's me with my white coat on. I'm not wearing today. I like to be a little less formal. When I would first give these lectures in 2009, I would stand behind there in a white coat and look very, very, I guess, medical, rather than just more one-on-one. So I trained in Philadelphia at Jefferson Medical College, one of the older medical schools. I'm board certified in a few things: internal medicine, emergency medicine, integrative medicine, and what they call anti-aging medicine. I got involved in this, after I trained as an internist and as an emergency medicine doctor, and was working in the emergency room, and I was so fatigued, and I didn't know why, and I couldn't sleep, and I was exhausted, and I went and saw a doctor who was a lot like I am. She was in Connecticut and got evaluated and found out that I had some thyroid problems and testosterone problems and adrenal fatigue, and these are all things that I had never heard of and didn't really care to know about, and ended up getting some really good advice on how to manage those problems, and it eventually involved me leaving that type of work and doing something more 9 to 5, where you sleep in your bed at night instead of being up all night and stressed. Stress management's a big part of being healthy, and I learned that. So that was my personal way I got into this field. And then I took a lot of extra training, including learning all about integrative medicine and passing the boards in that, learn how to actually do these things. So there's a picture through our front door in the Trade Center building, one of my assistants. That's another one. And my main weight loss coach, Phyllis, and we have another excellent coach, Caroline. And so let me say a word about preventative medicine. It's a lot of what we focus on. It's a lot harder to treat somebody after they've got a serious disease. Not that we don't try, but often you end up, getting partial results there. You can do a lot more if you catch someone in their very early stages of a problem, when they're maybe pre-diabetic, overweight, cholesterol's creeping up, maybe early bone loss, maybe just a small elevation in cholesterol. Then you can make some changes in their lifestyle and really prevent these bad things from happening and avoid all the medications and problems down the road. That's where I like to focus my efforts. Another thing I want to talk about, what is normal and what's optimal, and what I put optimal in the name of my practice. Well, you've all been to the doctor and you've had your test results, and they'll send you a little email and say, oh, your tests were all normal, come back in a year. What does that really mean? Well, it just means that you fall within the middle 90% of everybody else's values. That's what normal means mathematically. That's that dark blue area and that orange area next to it. The pointer, unfortunately, doesn't work on this screen, so I can't point with the laser. So you could be anywhere from here, just past the 2%, or all the way up to there at the 130, and it's normal. Now, in some cases, that doesn't really matter much because those numbers are fairly close together, but in others, such as maybe testosterone, where the low number is 200 and the high number is 1100, well, that's a big difference, and they're all, quote, normal. Thyroid's another one. So you have to know really where do people function best, not say it's just within the middle 90%. And that's what I do with each patient. I look at them and say, well, how are you feeling at that number? How are you feeling at this number? And where does that fall within that range? Maybe you do best up here, or the other person does best over here. We try to individualize it. We don't just look at what the lab report says, well, you fit in that range, see you later. Okay. So we're going to talk about hormones. So who knows what hormones are? A few people. They're often talked about. I mean, you can hardly get past a day without hearing some media thing about something to do with hormones, but no one really explains what they are. Hormones are messengers. They're chemicals made in your body whose job it is to take a message from one place to another place. And this part of your body is telling another part of your body what to do. And that's like an email. So, for example, testosterone might come in a woman from her ovaries or her adrenal glands, and then it would go to her brain and affect her libido. Or or it will go to her muscles and she'll be able to build muscle better and feel stronger. Or in a man, the testosterone would come from the testicles and it would go to the same places and do very similar things. So the thyroid makes some hormones, and they tell every cell in your body to do something, usually involved in energy and metabolism. So they're messengers. Hormones, therefore, since they are important messengers, are very important for wellness. If your hormones are not in the right ranges for you, then you probably won't feel as well as you could. This has a lot to do with many illnesses, and it also has a lot to do with symptoms of aging. As people get older, their hormone levels tend to change, and some people feel that a lot of the symptoms of aging are really symptoms of hormone imbalance. So keep that in mind. So that's what I'm going to talk a lot about. So some of the common hormones are listed here. These include estrogens, progesterone, growth hormone, cortisol, stress hormone, things that are involved in thyroid, such as TSH, T3, T4. ACTH is important for adrenal function. You've all heard of insulin with diabetics. Melatonin is a hormone, even though you can buy pills and it helps you sleep. It's normally made in the brain. DHEA, testosterone, pregnenolone, aldosterone, even vitamin D is a hormone. So how do they work? Well, we'll just call the blueprint up there a hormone, and then they talk to the cells, so the cells are the work crew, and then you add some vitamins and other things, such as, we'll call them tools, and then you add diet, which provides raw materials, such as, we'll call that lumber and bricks. You put it all together, you get a building, you get a human body, right? That's how they fit into everything. As I mentioned, some people feel a lot of aging symptoms are a result of hormone decline. I'll give you an example. Let's take an 18-year-old girl who has some horrible problem and ends up with a hysterectomy. Well, what happens to her? Well, within a few years, her bones start to weaken. Well, let's take a 70-year-old woman who's been in menopause since she was 50. She might have the same amount of bone weakening. So was that bone weakening due to her age, or was it due to the lack of estrogen and testosterone that her ovaries were making? But a lot of people feel that brittle bones are a sign of aging. Not necessarily. They're probably more a sign of a hormone imbalance that just happens to occur as people get older. A lot of other symptoms, such as wrinkling, hair loss, loss of muscle mass, even problems thinking and remembering, may be hormone related. Not exclusively, but they can certainly have a strong effect. So as I said, what causes a hormone imbalance? Many things, but growing older is a big one. Food, eating the wrong diet, exercise, not exercising, toxins we're exposed to in the environment, excess stress. These can all unbalance your hormones. So let's talk about bioidentical versus synthetic. I'm sure you've all heard the term bioidentical. Most people don't really know what that means. Bioidentical means it's a hormone that is exactly the way your body made it your whole life. It's not what the drug company made. It's not been chemically modified. It's identical to what has always been in your own body. Okay? Now that may be produced by a drug company, but it's still identical to what has always been in your own body. Okay? The drug company might also make another one that's modified chemically to make it last longer or do one thing more powerfully than the natural hormone, but those are the synthetic hormones. Those are not natural and they're not bioidentical. So the bioidentical hormones, you can think of them as a key, and they fit in the lock of the cells perfectly, the way they were designed to, and they do the same thing they've always done in your body since you were born. The synthetic ones might do things a little differently and have different effects. Okay, it's just a picture that shows a synthetic on the right and a bioidentical one on the left, and it can be a very small difference, such as that little change in the red circle, but it can greatly change the effect of the hormone. Estradiol is on the top left, and testosterone is on the top right. The only difference is a hydrogen atom. One little tiny hydrogen atom on the far left is missing in testosterone. That means that hormone will turn you into a woman or a man. That's a big difference from the tiny little change, isn't it? So when you take progesterone and you add a huge change to it, and, call it Provera, that has a big effect on how it works. Natural progesterone does certain things. Provera does some of those things, but it doesn't do others. When they studied this drug in Harvard at the Women's Health Initiative years ago, they found that Provera greatly increased the results of heart attack and even cancer, whereas natural progesterone doesn't do that. Right? But they both suppress breakthrough bleeding in the uterus, so they have the similar function there. But progesterone is weaker than Provera. They made Provera different in order to enhance that function to prevent breakthrough bleeding. But in the process, they altered its other functions. So that's why bioidenticals are, I think more predictable and more recognized by your body, certainly, than the synthetics. Then there's the issue of hormones being used that aren't even from human beings, such as horse estrogens, that are in a product called Premarin. You may have heard of that one. It's still commonly used. It's been around for many, many years. Premarin is a mix of many different estrogens and estrogen breakdown products that are extracted from the horse urine that they collect and make the pills out of. The problem is some of those are not natural to the human body, and when they are processed in the liver, they produce cancer-causing molecules that break down DNA. And the human molecule doesn't go through those pathways quite as much. So there's a difference in what kind of estrogen molecule you're starting with. Now, they relieve hot flashes just fine, but they break down into different things than the natural bioidentical estradiol does. Okay, so let's talk a little bit about menopause. So menopause has a lot of relevance to most women at some point in their life. It's technically the time when a woman stops ovulating and doesn't have a period for 12 months. And we confirm that by some blood tests that typically show very low estradiol levels. And they show a rise in a hormone called FSH. Okay? And, that process can occur many years, that process can begin many years before the actual last period. And that perimenopausal time can be a difficult time because you can have hot flashes one month and the next month you might feel okay. You get irregular cycles, you can have heavy periods, you can get PMS that gets worse and worse. A lot of these things can be helped by balancing of hormones. So the symptoms of menopause and the time around menopause, preceding menopause, hot flashes, night sweats, trouble sleeping, mostly due to loss of progesterone, hair loss, weight gain, mood swings, anxiety and depression, memory loss, dry skin, leakage when you cough, or urinary leakage when you cough or jump, vaginal dryness, loss of libido, wrinkling and thinning skin, headaches, heavy periods, irregular periods. You can see the lady there cooling off with the freezer. Okay, so estrogen is an important part of menopause. Its lack is what causes a lot of those symptoms, not all of them. It's made in the ovaries. It affects the brain, it affects memory, it affects mood, it affects the body, it affects the risk of heart disease. It maintains bone strength along with testosterone and progesterone. It maintains hair, skin, your shape. And progesterone is its partner. Progesterone balances a lot of the effects of estrogens. Okay, they're both made in the ovaries. So I always, when I talk to my patients, I'll say, well, think of estrogen as the gas pedal in the car, and you think of progesterone as the brakes. Okay, you don't want to drive your car with only one. So estrogen stimulates cells to grow. It stimulates breast cells to grow. It stimulates bone cells to build bone. It stimulates your brain cells to make memories. It stimulates skin to be thick and not wrinkle. It stimulates hair to grow on your scalp. It stimulates the lining of your uterus to thicken so you can have a pregnancy. Progesterone turns all that off, okay? Not in a bad way, but in a way that balances estrogen. It has a calming effect on the brain, so you're not anxious, and it helps you sleep at night. It also helps build bone, interestingly enough. It tells the breast cells to stop growing, which might make sense in women who have breast lumps or fibrocystic changes, or even precancerous lesions. Some would argue those should be treated with progesterone because they stop the division of cells. So be quiet. It tells the lining of the uterus to mature so that an egg can implant, and then when it goes away at the end of the menstrual cycle, it triggers a period. It even has effects on blood sugar and thyroid function. And, women who have low progesterone levels have an increased risk in breast cancer, and women who have, did I say that right? Women who have a decreased progesterone have an increased risk of breast cancer. Women who have higher levels of progesterone have a lower risk. So it seems to correlate even in clinical situations. What about testosterone? Yes, women have testosterone, men have testosterone. In women, it's made in the ovaries and the adrenal glands. So at menopause, you lose about half your testosterone because you're not getting the ovary testosterone anymore, but you still have some from your adrenal glands, but only about half. So testosterone in women is important for energy and libido, and it helps to burn fat and build muscle. It keeps the bones strong, it improves your mood, gives you motivation to do things. A lot like what's in men. This is an interesting study that I threw in here. They showed that when they gave a testosterone spray to women, their memory and ability to remember things improved. So it has definite effects on the brain. They use something called, I thought it was kind of interesting, the International Shopping List Test, whatever that is. So I guess it's what you can remember a shopping list, how many things. This is a slide that was on my computer, which wouldn't start tonight, so I'm working from a thumb drive. But there are some studies that just came out this year that showed remarkable growth of bone with testosterone use in both men and women. So this is something that is not yet an indication for testosterone in women, but it probably ought to be. And in my practice, when we treat women with testosterone, we frequently see the bones getting stronger without giving a lot of these drugs that are commonly used for osteoporosis. There is research to support that. What about cancer? Everybody's always worried about this. And you go to your primary care doctor and they say, oh no, you don't want to use any hormones because you might get breast cancer. Is there any truth to that? Well, there was a study that everybody's always quoting, done at Harvard, of course, and it was called the Women's Health Initiative. Has anyone ever heard of this? Everybody's heard of this. And they gave the horse estrogen, Premarin, and they gave the artificial progesterone-like drug, Provera, and they discovered that women had a higher risk of breast cancer. So all of a sudden, they said, oh my goodness, nobody should be on hormones. An estimated 160,000 extra deaths occurred since then because of hip fractures and falls because women were taking off their hormones. Well, later on, and I don't know how this happened, but you would think they'd figure these things out at the beginning, but later on they looked at the data a little more carefully, and they had broken the women up into women who had a uterus and women who didn't have a uterus. So the women who had a uterus got the Provera, the artificial progesterone, so they wouldn't have bleeding from the Premarin. The women who didn't have any uterus only got the Premarin. They didn't get the Provera. They found that the risk of the women who did not get the Provera, and it's hard to follow, was not really much more above baseline, which is interesting because it's still horse estrogen that has some breakdown products that increase the risk of cancer. But they found most of the increased cancer risk was being caused by this progesterone-like molecule, which is artificial. It's not real progesterone, it's a synthetic version of progesterone. So that was interesting. So maybe estrogen isn't so bad after all. But they weren't studying bioidentical hormones. Neither of these are bioidentical to humans. So the conclusion I would make is horse estrogen slightly increases your risk of breast cancer if you follow women for 10 years. Artificial progesterone, known as Provera, definitely does. but you can't comment on bioidentical estradiol and natural progesterone with this study because they did not look at those drugs or those hormones, what I call them hormones. So did anybody? Well, yes, they did. There was another study done, which you've never heard about probably. It's called the Keach study. It was done in a number of different hospitals. They followed women for 7 years, and they used bioidentical estradiol. In this case, it is a patch. And they used bioidentical progesterone as a pill. And guess what happened? There was no increased risk of breast cancer. In fact, there was a trend towards less in the women who got this hormone concoction compared to women who got nothing. They got the sugar pill. Okay? So isn't that interesting? So when someone says there are no studies that say bioidentical hormones are safe, they're wrong. And there are studies that show that they even don't increase the risk of breast cancer. This had more women in it and went longer than the original study. Okay, there have been several other studies in Europe that have also looked at the use of bioidentical hormones indirectly. In some, they were looking at blood clots, and they kept records of all the drugs that anybody was on, 30,000 people, and they pulled out all the people who were on hormones because they thought that would be a risk factor, and then they could secondarily look at how many of these people got cancer, how many people didn't. And they also found that the bioidenticals were safer than the synthetics. So there is data to support this. Okay. And then coming back to that original Harvard study, they finally looked at the data again recently and found that actually the death rate was no different between the people who got the Premarin Provera and the ones who didn't get anything. They had more breast cancer, but they were caught early and treated, so they ended up not having an increased mortality, which is nice to know. So now the consensus has sort of swung back. You know, at my latest internal medicine training at Harvard, they said, well, now we think it's okay to use hormones, in their view, synthetic hormones, of course. We know we were wrong. That's what they're saying. You know, we jumped the gun saying don't use it. Now we think, well, we've gone 18 years now. We know that the death rate's no different. We'll just do more breast cancer treatments. Well, I mean, I think there's another way to look at it. Maybe we should just use a safer hormone and maybe avoid the whole problem. But that's my opinion. But anyway, the North American Menopause Society, the gurus of menopause treatment, now say that the risks, the benefits of hormone replacement exceed the risks. So it's no longer no hormones for everybody. You probably ought to just pick and choose who you're going to treat on an individual basis and, you know, take into account their risk factors, and obviously their past history makes a difference. Is there a question, someone?
I have questions.
Yeah.
Where do they source the bioidentical hormones from? If it's not coming from animals and it's not being made in the lab, like what is the
Well, that's a great question. The root material is a yam.
Okay.
It's a Mexican yam that happens to make a chemical that can be turned into hormones. It's 98% of the way there. So they harvest these yams, they purify this chemical out, and I don't recall the name of it. And then drug companies do modify that in the drug company labs and make the bioidentical hormones. So your big companies like Merck and Johnson & Johnson, the same ones that are bringing you Premarin, are also making your bioidentical estradiol and progesterone and testosterone. And in some cases, they're selling it under their brand names, like the Vivel Dot patch, or generic estradiol patch, or oral progesterone capsules, which are all bioidentical, by the way. You can get them at CVS. But they also sell them in bulk to places like this pharmacy, where they will mix them into individualized doses in creams or capsules or however you know what the doctor orders to make them individual doses just for you, which is what Dr. Krakoff was mentioning, as opposed to fitting into slot 1, 2, and 3. You know, you get a dose that's just right for you. But they're FDA approved, they're safe, they've been checked, which is why it's nice. They come from a lab, from a drug company that's closely watched to make sure they're making clean, perfect products. So that's a lot different than collecting horse urine and making it into a pill, I think, which is what they also were doing to make Premarin, which is the cleaner drug, right?
So why can't you just eat the yams?
Yeah, that's a good question. There's a funny show on Netflix where there are some women making a potion out of yams. I forget the name of some. Maybe one of you have met it. I've seen it, but it's really funny. But it's not close enough. Remember, we're talking about the lock and the key mechanism. It would be really interesting if you could just eat soy or, eat, red clover or black cohosh, which are herbs that women have taken for menopause, and it would relieve your menopausal symptoms. But it's not quite perfect enough to trick your body into thinking it's real estrogen. It's close, but not quite. All right. So the bottom line is, I think that most doctors realize that while there is truly a risk of increasing your cancer rate, breast cancer in particular, if you give estrogen without progesterone, it's not as high as we thought it was, 10 years ago. Even for primary, okay? So the other thing to remember is there have been no studies that have been done on the bioidentical hormones that showed an increased risk of breast cancer. There haven't been a lot of them, but there have been some, and they did not show it. So, that's reassuring.
So could you imagine that women could be on them for years and years and years, the bioidentical hormones, after menopause?
Well, that's a great question, because the conventional advice is to use these hormones for the shortest amount of time that you can. But who decides what that time is? The doctor. And when they stop, then all the problems that you were treating with them come back. If your bones were strong because of the hormones, when you stop them, they're going to start getting weak. You couldn't sleep. You had hot flashes. You couldn't remember where you were or what you were going in the room for. These things all come back when you stop taking your hormones. So I would imagine that you could take them longer. It isn't the current advice, but I tend to feel that that's reasonable as long as you're doing close monitoring of your patient and frequent
Susan,
mammograms. Yes?
20 years on hormone replacement,
Yeah.
and I'll tell you, there's no take it for 10 years and stop. If you're on this, you are not going to be able to go off.
Correct.
Because you will go into withdrawal. So
Yeah.
that is, I think you're on for life if you're going to be on it.
It's probably true, although I've had some patients who have decided they don't want to stay on their hormones for whatever reason, and that's certainly an appropriate decision.
Yeah.
So you're here to provide a service to your patient. If they want to go this route, then you're there to help them do it safely and appropriately monitor things and blood levels and symptoms and mammograms and everything. And if they want to stop, that's a perfectly valid choice.
What are the perceived risks of the bioidentical in the long term then, if you're not talking about an association with cancer?
Oh no, don't get me wrong. The problem is always in how you use things in any drug. You can take aspirin and take too much and get a horrible bleeding ulcer and die from it. That doesn't mean everybody shouldn't take aspirin in the right dosage if they need it. Just as that's true if you give estrogen in too high of a dose and you don't balance it with progesterone, you can probably increase somebody's risk for a lot of problems. So, including weight gain, breast tenderness, breakthrough bleeding, even possibly breast cysts and breast cancer if you give it in an unbalanced way. The way the body works is these hormones are balanced, and that's the point I'd like to get across, is if you do things properly, you should not increase your risk.
What about risk of anything is what she's asking. So if it's balanced and bioidentical, could you then perhaps be on them?
Yeah, well, there's always a background risk of breast cancer. Depending on your family history, it might be 1 in 10, it might be 1 in 30. But that's not going away. I mean, if you monitor your patients, you may, fortunately, at some point, someone might be detected with a breast lump that turns out to be cancerous. What I'm saying is the data that I have does not suggest that the risk is increased from what is normal in the background population. So that's my feeling.
I watched on Mercola, he interviewed, I think, the leading doctor who's Harvard trained on, he was in fertility first, and his wife, I think, got cancer, and then he switched over to hormone replacement in women, I think in men too. But he suggests that the first 10 years after you enter menopause is critical that women be on he said synthetic was probably better, I think he was leaning into it. But bio or synthetic in order to prevent memory issues, Alzheimer's, I think as well as cancer. So you think you should at least...
Right, even there are doctors even in conservative institutions like that feel that way. It's good. It's a difference of opinion. And eventually the truth will come out, because women have been on these therapies for many, many years, and we see the outcomes. In my practice, I've not seen I've hardly ever, I think we've been maybe 3 or 4 patients that have developed breast cancer out of hundreds. So it's a pretty low incidence.
One more question.
Yeah.
Are there bioidenticals for birth control, not just menopause?
No, that's the thing. Bioidenticals are designed to make you fertile. That's the whole point.
I mean, oral contraceptives for. I have 2 teenage daughters.
No, there really is no way.
Of course, the benefits outweigh the risks, but if they could be taking something more natural to their body, I would prefer that.
I usually recommend women use the copper IUD, Paragard, for birth control. It doesn't have any hormonal effect. It works very well. The other option is the Mirena, but that uses a synthetic progesterone that can cause its own problems. All right, as I said, I'll talk to them about something else. Vitamin D is a natural hormone, available on all sorts of vitamin store shelves, but it does a lot of really important things. It helps your body fight infections, especially viruses. It's anti-cancer. It's associated with, high levels are associated with reduction risk of autoimmune disease. High levels are shown to associate with a lot of things, less risk of diabetes, lower hypertension, lower risk of heart disease, and it goes on and on. Obviously, it's also needed to help build bone and absorb calcium. The usual dose is recommended about 800 units, maybe 1,000 units by conventional doctors, but when you measure people's blood levels, in order to get to the levels that are probably optimal, which is 50 to 100, you really need about 2,000 to 5,000 units a day. So you can take that as a little tidbit. Let's talk about men, andropause. So andropause is the time when testosterone declines and men start having symptoms because of it. Usually happens in the 40s or 50s. May never happen. My dad, for example, is almost 80, and I checked his testosterone is over 700. But unfortunately, most guys do have a problem with lowering testosterone sometime around midlife.
Does your dad still have all his hair?
No. No. So this is a graph showing testosterone levels with age. On the left, it's about 900 at about 20 years of age, and on the right, it's about 100 at about 80 years of age, and that's an average. So, it drops at about 1% to 2% a year from the peak. Optimal testosterone levels are a debated subject. You can go to doctors who say, well, I'm going to wait until you hit the bottom of the normal range of 250 or so. Then I'll give you testosterone, and then we'll just keep your level around 800. Well, that kind of makes zero sense to me, because if you wanted it 700 or 800 under treatment, why did you let them drop down to 250 in the first place? But that's what a lot of doctors do. They won't give you any testosterone until you hit 250. Even if you have symptoms, they just won't do it. I take a more individual approach. I certainly, look at the patient and see what kind of symptoms they're having, and if it can be attributed to the decline in testosterone, and then I'm willing to treat them. I also look at not just total testosterone, I look at things like free and bioavailable testosterone, which require different kind of testing. So what is optimal for one man may be different than from another. One man may feel great at 280, and there are reasons that can happen. Other guys don't feel good even at 700. And it really has to do with what is the free testosterone. And that's a little complicated, more than I need to go into here, but the total doesn't give you the whole picture.
Is there any units on the y-axis?
Units,
Those nanograms per deciliter or something?
they don't list it there, but probably, I think it's just a graph to give you a general concept, but probably nanograms per deciliter. So why do testosterone levels drop in some men and not others? Well, a lot of it has to do with toxic exposure. A lot of the chemicals we're exposed to every day, such as pesticides or Roundup, for example, plastics, fumes from plastics, BPA. A lot of them can look a lot like estrogen to the body, and estrogen tells your brain to produce less testosterone. So if you have high estrogen levels or you have high levels of chemicals in your body that look like estrogen to your brain, you will make less testosterone. Pollution from other things like drugs and metals can affect stress, can lower testosterone. Alcohol lowers testosterone. Not sleeping well lowers testosterone. Sleep apnea can lower testosterone. Obesity, because you generate more estrogen, can lower testosterone, and also because you're prone to sleep apnea. Exercise increases testosterone, so therefore if you don't exercise, you'll probably have lower testosterone. Deficiencies of nutrients like zinc and various vitamins. Drugs, opiates, statin drugs, cholesterol meds, marijuana, all of them can lower testosterone. So it's a wonder we have any testosterone. It's really, when you think about it. So this is the very broad normal range, 200 on the left, 1100 on the right. In the middle, 90% of men fall in there somewhere. It doesn't mean they're all the same. It doesn't mean you should wait until you get 200, at least in my opinion, to treat them. I think you need to look at individual patients and what are their symptoms before you make that decision. Declining testosterone is certainly related to reduced muscle mass, change in body composition, more fat, less muscle, loss of bone. That's pretty well established. Definitely linked to lower libido. Interesting, there are a lot of studies out there on testosterone in your heart, and some of them conflict with each other. And but there are definitely some good studies out there that showed that higher levels of testosterone are associated with lower levels of heart disease, just like there are a couple studies out there that for some reason showed that treatment with testosterone seemed to increase the risk of heart attacks. But they've been heavily criticized because these studies weren't done very well. And I could go into the detail, but most doctors don't think that the results on those tests were very valid. Testosterone is a risk factor for type 2 diabetes, so when you have low testosterone, your risk for type 2 diabetes is higher. That makes sense because when you have more testosterone, you build more muscle. You build more muscle, you burn glucose better, you have better control of your blood sugar. So when you have better testosterone levels, you can exercise, you may not need as much insulin. Probably has also something to do with diet. Now let's talk about cortisol. The adrenal glands make cortisol, that's known as a stress hormone. So what is it really for? Well, it's to give you energy in a dangerous situation. So if your bus is coming down the hill at you with no brakes, you might need a surge of energy to run across the street really fast so you don't get hit. Well, that's what cortisol is for. And then it's supposed to go away and not be at a high level. But when you're constantly stressed, cortisol never goes down, and then it can have problems. Then it can affect your body in bad ways, and it causes your body to break down muscle tissue, to store fat, to break down bone tissue, and increase your risk for high blood pressure, diabetes. Sometimes we don't have enough cortisol, and that can be caused by autoimmune disease. It's very rare, but it can happen. But more often, it's just a slight decrease or a relative decrease where you don't have enough during normal stressors of the day, and we sort of call that adrenal fatigue. So, that's a situation where while you can still make cortisol, you just don't make it as much as you need it. And people feel depressed, fatigued, burned out. And this is a hard slide to read, but it's just a picture of a very stressed out person and an exhausted person. So does it mean you can't make testosterone? Cortisol? No, it doesn't. It just means that because you've been so stressed for so long, your body's kind of adapted and become, less sensitive to it, and your body starts telling the adrenal glands, all right, you don't make so much. And then when that high stress period isn't there, say on the weekend, you're just exhausted because there's none. So we can test for this. We do a saliva test, easy to do. You can measure the cortisol levels throughout the day. And, normally we see a high level in the morning and then it declines throughout the day to a low level at night so you can sleep. But in this person, it's kind of flat the whole way across. That's abnormal. How do you treat that? Well, you don't just give more cortisol. You can treat that with a lot of herbs and nutritional products that'll help your body readapt to stress. Things like ashwagandha and rhodiola, ginseng. Make sure the body's getting the right nutrition, vitamin C, pantothenic acid. Make sure the person's sleeping at night. Night shifts are horrible for this problem. That's what I did with mine. This was a graph that was very similar to what I had when I used to work in the emergency room. I had no cortisol. Flat. I thought it was a lab error.
How does caffeine affect
It boosts it temporarily.
it? And that'll show up on the test at home?
Not the same pathway. Progesterone will actually increase it though, because that is a pathway that will go into cortisol. DHEA in women will turn into testosterone. In men, it will mostly turn into an estrogen called estrone. Not a great idea. Okay, so let's talk a little about thyroid, another hormone we treat. What does it do? It maintains your energy, increases burning of fat. If you have the cold hands and cold body temperature, that would be a symptom of hypothyroidism potentially. Affects hair and skin. People with low thyroid tend to lose hair. They tend to have very dry skin. There are a lot of different thyroid hormones. There's T4, there's T3, there's reverse T3. They're all important. We test for all of them. You probably have not heard of all of them, but they're all important. And they're regulated by another hormone called TSH, which is pretty commonly tested for. And then there's growth hormone, which is made in the pituitary gland. It does some interesting things. When you're a baby, it makes you enlarge and become an adult. It makes your body grow. But when you're an adult, you still need it. It kind of maintains things. It's kind of a repair and healing hormone. You don't need as much as you did when you were growing from child size, but you need some. And there are rare people where they actually are deficient in this. It's not very common, but it does happen. And if that's present, if there's a deficiency, you can treat them by either replacing growth hormone or using another hormone called semarelin that triggers your body to produce more growth hormone. And it's also affected by lifestyle factors. So if you want more growth hormone, you have to have deep sleep at night, because that's when it's made. If you're not sleeping, you won't make much growth hormone. You're going to age more rapidly. You're going to look unrested. Heavy lifting, heavy weights, eating high protein diet, these all help boost growth hormone. Not drinking and not eating sugar before bedtime. So those alcohol and sugar both inhibit growth hormone release, and limiting calories can boost it. All right, so that's an overview of a lot of different hormones and situations. Why would you consider using bioidentical hormones? Well, the answer is pretty obvious. You have signs and you have symptoms that suggest you have an imbalance or a deficiency, whether that's menopause or hypothyroid or low testosterone or something else, PMS, for example. You see a doctor, you have some tests done that confirms you have a problem, and you want to remain healthy and vital. So, as we talked about, a lot of the aging symptoms may be due to imbalances of hormones. So how do we do the tests? Well, on cortisol, we also use saliva, although you can use blood, but I think saliva is more sensitive. For most of the others, a blood test is best. Sometimes we'll use a urine test. And, in my practice, we always talk about diet and nutrition. We talk about exercise. We talk about stress management. How do we deliver hormones in women? Sometimes we'll use an oral hormone like progesterone in a capsule. We don't usually use estrogen orally, and we don't use testosterone orally. We can use creams, which are often made in pharmacies like Johnson, where you just rub them on your various parts of your body once or twice a day. Sometimes we use vaginal hormones, and sometimes we'll use pellets. Pellets, I'll show you on the next slide. If you can see a little rice-sized cylinders, and those are actually implanted under the skin into the fat layer, and they're really nice because they can last up to 5 months and have a very steady release of hormones, so you don't have to rub a cream on your body every day. So in the right patient, that might be a good solution. Particularly women who've had a hysterectomy, so there's no risk of breakthrough bleeding. They're ideal. Sometimes men like these because it's convenient. So that's an option in our practice. Not every practice does that. In men, we can give testosterone through a cream that you rub on your skin. You can use injections or, again, pellets. For thyroid, most of the medicines are in fact, all of them are oral. Growth hormone is an injection. Adrenal products are generally oral.
What is the problem with oral estrogen, estradiol?
Well, there's a problem with that. Even bioidentical estrogen, if you swallow estrogen, it increases your liver's production of certain blood clotting proteins. So that's why you get an increased risk of blood clots from certain oral estrogens.
Can you dissolve it under your tongue?
I don't think that would work because it'll get down there eventually. That's why we use creams.
Okay.
Interesting, the studies have looked at that. And in cream estrogens, you don't see the increased risk of blood clots. It has to go through your liver, and that requires you swallow it.
Thank you.
Yeah. That's not moving. What did I do? It was working before.
What's a cap? Is it encapsulated or is it just the material itself dissolving?
No, they're a pure crystalline hormone mixed with some binder, either a stearic acid or cholesterol. But it's a hard glass-like thing that completely dissolves. So it's going to work for me now. Okay, good. So there's a picture of the cream on the top right. This is a vial that has testosterone in it. That's progesterone in a bottle. That's Livell patch, which is widely available. It's an estrogen patch, which is bioidentical. So why would you want to do this? Well, obviously you get a better quality of life. If you have menopause or andropause, you'll feel better, relieve your symptoms, relief of hot flashes and night sweats. It may assist in weight loss, improve libido in both sexes, improve mood, improve sleep, energy to exercise, and exercising is important. And long term, you may have some health benefits. You may have a reduced risk of heart disease, according to some studies. You definitely would have reduced risk of osteoporosis, improved memory, better mobility, able to exercise. So as I said, the first stage is you see somebody like myself, have them evaluate you, find out what your symptoms are, check your labs, and then you address other issues. In my practice anyway, we address chronic illness, prevention, look for evidence of toxicity, think of strategies to try to reduce it, talk about nutrition and fitness. That's how we do it. We only use pharmacies like Johnson that are PCAB certified. That's really important. That means they've been inspected and they produce their compounds at a very high quality. There are a lot of compounding pharmacies out there. They're not all at that level. We only use those. Sometimes you might ask, why is my practice different? Well, if you think about it, who do you go to for thyroid medication? Well, you might go to an endocrinologist that specializes in thyroid. But is he going to do your menopause? No. You have to go to a gynecologist for that. And then who's going to treat your diabetes? Well, maybe your PCP. And then who's going to look at your adrenals? Well, maybe the endocrinologist, but he is not going to believe you if you tell him you have adrenal fatigue. You kind of have to see somebody that knows about all of the things at once, because they all interact. And then, that tends to fall into the field of internal medicine, but even they're not up on all of it. And so, that's where I come in. I'm going to skip this. We have a weight loss program there. It's very effective, and we're going to talk about that one. Except to just show you my coach and a few happy clients. All right, here's a patient. I have 2 more patients to talk about. So I'm going to give you 2 cases, one woman, one man. So this is a female patient. She's 47, and she's an executive, and she came to me because she was worried that she had osteopenia on her bone density scan. And she had insomnia, she had hot flashes, she had low libido, dry skin, terrible PMS, she wasn't in menopause yet, breast tenderness, fatigue. She also had irritable bowel symptoms. She was putting on belly fat. Her memory was failing. She was exhausted, but she couldn't sleep. She had everything. She had tried herbs. She had tried black cohosh, vitamins, calcium. Her primary care doctor said, no hormones for you, but you can take an antidepressant. And she didn't want to take any drugs for the bone loss, so because they have a lot of problem side effects. So we tested her, and she had, relatively low estrogen, progesterone, testosterone, DHEA. She had low cortisol. I mean, she's a very stressed woman. She had lower thyroid function than she should, although she probably wasn't technically hypothyroid. Low vitamin D. She did have low bone density. Fibrocystic breasts, uterine fibroids, and so on. So there was a lot to be done for her. We did a lot of nutritional work with her. We did use hormone creams, which you can use even before menopause if you time them with the cycle. And we gave her some herbal supplements for her adrenals, ashwagandha, ginseng, and so forth. We put her on a bone regrowth supplement program and taught her about the paleo diet, which I'm a big fan of. And at 2 weeks, she felt much better. All the perimenopausal symptoms got better. She felt her memory was back at 10 weeks. Her GI symptoms got better with the paleo diet, which is about 80% of what I see. She had a lot more energy. She lost 9 pounds. Then added up from 12 pounds of fat loss, 4 pounds of muscle gained. And yes, these are not unusual results. I mean, I didn't pick my best patient. This is an average patient. This is a test that the company that did her saliva testing ran, and just lists all her symptoms. And on the left, those dark bars going across are different symptoms. You can see how many there were. And she fills this out, I don't. And I just get the report, and you can see on the right, she just had a couple things left. So much better. So that's what you can do for somebody. Here's a man, 45-year-old attorney, fatigued, having joint pain, memory loss, no motivation, low libido, falling asleep after he eats, too much fat, his cholesterol's too high, has high blood pressure. He told me he used to play with mercury thermometers as a kid, so that's probably a problem. Probably had some mercury toxicity. Drinking a lot of caffeine, eating a poor diet. Told he needed to go on a statin drug by his doctor. He didn't want to. So, and I saw him. He had mild hypertension. He was a little bit overweight. And his body fat was 28%, should be about 15 maybe. And his cholesterol was high, 304. His bad cholesterol, LDL, was high at 221. His good cholesterol wasn't too bad. It was 59. Triglycerides were a little bit high. His hemoglobin A1C, which is, as it goes up, increases your risk of having diabetes, was creeping up at 5.8. His vitamin D was low, and his testosterone was kind of low at 397. He's not out of that normal range, but he's in the lower half of it, lower third for sure. And so what did we do? Well, I gave him my talk on diet, told him to eat a Paleolithic diet, low carb, adequate protein, lots of veggies, good fats, low sugar. We put him on some testosterone. We started with a gel, and then we switched to the pellets. He had some degree of adrenal fatigue as well. He had low vitamin D. We treated that. And 2 months later, he felt much better. Libido was back to normal, able to exercise. He felt his memory was normal, which is important as an attorney. He followed the paleo diet and cut back greatly on the alcohol and refined sugars and carbs. You can see his blood pressure improved, dropped down to 120/80, didn't need drugs. His body composition improved. Body fat, the second visit was 18%, much better. And look at his cholesterol, went total cholesterol 304 down to 186. And LDL went from 221 to 119 with no drugs, which is pretty good. So that again is a pretty typical patient. I mean, not the worst, not the best. So I'm going to stop there. I've talked about a lot of things. Are there any specific questions anybody has? Okay.
Do the bioidentical hormones help with inflammation in the body?
It's a good question. I mean, there is some research showing, an association between imbalances in testosterone and estrogen and inflammation. But I don't know that I would use it specifically. I think inflammation is much more linked to diet and the consumption of carbohydrates and gluten and grain and sugars and foods you may have allergies or sensitivities to more than hormones. Certainly they have an effect, but I don't think that I would just prescribe a hormone because of inflammation.
I had DCIS 10 years ago. Right away, the first you're going to get from every doctor, you have to come off the hormone therapy. Now, the breast cancer treatment, I finally found a doctor who said it's more important. I have bipolar. He said that it's your quality of life and you can make the decision. He's a very well-known doctor. He's minority, although there are more now that will treat women that have had breast cancer. But the biggest issue for all the doctors is that they don't like the progesterone with the estrogen. A couple of my, because they, according to this is matched out, the both of them increase the division of the breast together, but you can see me still here, and I never had a reoccurrence. So they lowered my progesterone to 75 instead of the standard dose, just to make people happy, and I also felt better. But there's a lot of progress now with this.
There is a lot of progress, and the misunderstanding comes from that women's health initiative where they gave the Provera.
Exactly.
And the problem is most doctors think Provera is progesterone.
Right.
And you would think at Harvard they would know the difference. But they're different drugs.
I think that's what they're thinking.
They're thinking that, well, I don't want to give her Provera because I know the Provera was the real problem. But they're thinking, Provera is so similar to progesterone, then I don't want to give progesterone either. That's wrong, because there's so many studies out there that show that progesterone actually kills breast cancer cells in the lab. We don't use it to kill people, kill breast cancer women. But there are
I heard of that too.
Yeah, but in the lab I found it. I actually did a search. I looked everywhere I could online to find an article showing that progesterone had been proven to cause any kind of cancer. I couldn't find anything, not one study anywhere on real progesterone. What I did find is tons of studies showing high progesterone is associated with a reduced risk of breast cancer. Progesterone, though, not Provera. So we got to talk about the right medicine with your doctor. Okay, so you tell them.
Yeah, I had to learn all. I had to.
You're confusing Provera with progesterone.
They may still be thinking that way.
They're thinking Provera and just generalizing progesterone.
Yeah.
Just like Preventative to them is the same as estrogen. It's not.
Right.
You need to look at the nuances of it.
Are there any negatives at all to cell therapy?
Well, I mean,
Long term or?
with any drug, I don't want to glorify anything, okay? With any type of medical therapy, there are pluses and minuses, okay? The real key is individualizing to the patient, knowing the right dose, following with the right testing, and knowing how to adjust things. For example, if you're treating a woman who has an intact uterus and she starts getting breakthrough bleeding, that's a risk when you give her estrogen, from any kind of estrogen. Okay, Premarin, bioidentical estradiol, creams, pellets. you have to know how to deal with that, okay? And it may involve increasing the progesterone to balance it, or reducing the estrogen dose, working up for endometrial hyperplasia with an ultrasound or a DNC. You just go through the process. But that's the same with any drug. I mean, any drug you take has a whole list of adverse side effects. If you watch a drug commercial, usually includes death and everything else very, very quickly, so you don't hear it. So it's not is there a negative? It's really, there are possible adverse effects, and the doctor you're going to should know how to deal with them, and that's the right answer. Yeah.
This is a little off the hormone side, but you deal with Johnson. Do you ever use low dose naltrexone in your
Yes, we
practice?
do. Yeah, for autoimmune disease. Yeah. We do all kinds of functional medicine. This is just a little fragment of the practice that I'm focusing on today. We don't. We submit. We have the patients submit to their insurance, and sometimes they'll get reimbursed. We're a small office. We can't afford the overhead of dealing with the insurance companies directly. It puts you under. Yes.
I have a question. Is there an age in which it's too late to begin doing bioidentical hormones?
Well, as somebody mentioned, they recommend if you're going to do it, you start them early.
Mm-hmm.
And that's not because of any great data. I mean, they haven't done really good studies on people. They just had an age cutoff.
So what is early?
They had age cutoffs on the studies where they treated women, so they don't know what happens after that.
Oh.
There's a theoretical increased risk of heart disease if you start hormone therapy at a later age. But, my feeling is I think they have benefit, and I would, as long as you explain potential risks and benefits, I think there's so many possible positives that I personally don't object to starting a patient who's older. If you start very low dose and you carefully follow them, but you have to choose your patients carefully.
When doing treatment for bioidentical hormone, is there a length of time based on different cases?
Well, the conventional ones, they suggest less than 5 years. But as I've told you, I have patients that have been on hormone replacement since 2009, and they have no intention of stopping. And I think it's really up to the patient. I don't think as long as there's no adverse effect, then I don't see why you need to stop. But I follow my patients closely. We get mammograms every year. They have to have their GYN exams. We follow their blood tests. We try to do things as safely as possible. So that's my view of it.
Can you estradiol and estrogen? One of your slides said low estradiol, but estrogen dominance. I don't think I understand that.
Well, that's an interesting question, because you can be estrogen dominant if your progesterone and estrogen is out of balance. So your total estrogen may have started up here, your progesterone was here, and now your estrogen's here, and now your progesterone's down to 0. You're going to be estrogen dominant.
Okay.
This is how after menopause you're going to have 0 progesterone, but you still have a little bit of estrogen coming from other sources called estrone, not estradiol.
Okay.
That estrone is there and it's unbalanced by anything, so you're estrogen dominant. So postmenopausally, that will make you have weight gain, possibly breast tenderness, but it's not enough estrogen to prevent hot flashes. So you can have symptoms of low estrogen, hot flashes, and night sweats, and still have symptoms of estrogen dominance. Which are,
Not balanced by
yes.
progesterone.
So in that case, you could just give some progesterone, balance things out, or you give progesterone and some estrogen, estradiol, though, not estrogen.
Okay.
Estrogen has its own problems. It tends to increase your risk of breast cancer more than the other estrogens.
Okay.
That's why we don't use estrone.
Estriol, are you okay?
Estriol is an interesting one. That's one that's usually only made in pregnant women, but we do use it because there's some suggestion that it can reduce your risk of breast cancer or cause less risk than estradiol and estrone. So we usually use a mix. If we're doing a cream of estradiol and estriol, and we call it Biest. Yeah.
Well, once somebody's on hormone therapy, how often do you retest to see if things need to be adjusted?
The first visit, we'll do a bunch of labs, and then we'll usually follow up 2 months later. And when we get to a point, we might be checking yearly.
Okay. Now, does insurance pay for the hormones?
Depends on your insurance and what we're ordering. For the compounded, I find probably not, but they don't tend to be as expensive as the brand name products. For a lot of the brand name products, they will cover it. They often do cover the lab testing. How are we doing on time?
Whatever works for you, like 8:50.
It's up to you. You need the room.
Yep.
Okay. All right.
You mentioned about the different kinds of estrogen. The biest versus triest.
Right. So Triest has estrone in it.
Right.
And that was popularized by Jonathan Wright up in Washington back when no one else was doing hormone replacement in the whole country, and he figured it out. And started doing Triest. And the reason he did that is because he just looked at what was in the urine and said, all right, estrone, estradiol, estriol, I'm just going to copy it, same ratios, put it into a cream. There you go, Triest. And, it worked. And people just started doing it until, they looked at what was in there, and there was a reason your body's getting rid of these things. Estrone increases the alpha receptors, which tend to increase your risk of breast cancer more than the beta receptors, which are stimulated by estriol. Estradiol has both. So we use the more potent estradiol as well as the relatively low cancer estriol in biest instead of triest.
And what's the ratio that you now go with? Because John can say that.
Well, we do different ones. I mean, I'll do 50-50 or 80-20. It depends on the patient. Yeah.
This is not for me, but on the testosterone side for the guys, I've read a lot about how you get sensitized to it over time, and that you end up in a worse state. Is that just the synthetics, or is that the case?
Well, testosterone has to be kept at the right level. So the problem is a lot of guys will use too much, especially the bodybuilders. They're notorious. They just keep using higher and higher doses, and that's the wrong way to do it. When we do it, we're keeping people in that upper third of the normal range. And when you keep men in that range, they don't tend to become desensitized to it. So if you keep things we're keeping the hormones in the normal range. We're not trying to exceed that.
Typical doctors' practices doing hormone replacement, was that a problem?
Well,
Was that a
so there's a big
and
issue with that. Yeah, because they'll put you on, androgel or injections, and they don't understand the concepts and they don't follow the levels, and they certainly don't know that testosterone is turning into estrogen. And so
the
their
stuff I was
patients.
reading was like how they were doing it wrong.
Yeah,
in the traditional side.
Yes. If you do it right, they don't become desensitized. No.
Do you ever use progesterone to treat men's prostate problems or?
Yeah, that's an interesting point because it does do the same thing as finasteride and Propecia.
It does.
Yes. I have one patient who wouldn't take his finasteride, and he loves progesterone. He swears by it as a cream. Won't give it up.
Okay, thanks. Probably not.
It's not as strong as finasteride, but it does seem to work for him, and it affects the same enzyme.
Right.
The hormone imbalances add to autoimmune, like psoriasis, do they interplay with?
I think that it's more diet, really is, or exposure to certain other factors like bad gut bacteria, viral exposures, exposures to mold, even chronic Lyme disease. I mean, all of these things can throw your immune system out of whack, essentially, so it starts to function incorrectly and attack itself. Certainly being estrogen dominant is associated with autoimmune disease, but I don't think it's the driver.
And would doing hormone replacement aggravate autoimmune conditions?
No, I don't think it would aggravate it. It might help it.
Do you test for things like mold and all those things if somebody does have those?
We don't do that routinely, but it's part of the things we can do for the right patient. Mold is a totally different subject, but mold can make people miserable, and chronically fatigued, and it's a real problem.
You didn't give a cutoff on age.
I don't have a cutoff.
Okay,
I have patients
so-
who are 88. I mean, I don't think there has to be a cutoff. You may want to discuss the risks if there's an increased risk of heart disease or heart attack, that's something that your patient needs to know. But your patient needs to also have the right to say, my quality of life is important. I want strong bones. I want a strong brain. I want to stay fit and vital. And so you just have to understand the risks and benefits, just like with any medication.
Will bioidentical hormone replacement increase bone mass after, say, in your 60s and 70s?
That's been my experience, yes.
Yeah, it will. Okay, great.
Do you see anything on the other spectrum, side of the age spectrum, younger patients with insufficient progesterone? Or
Yeah, now and then I'll see someone in their 20s, women in their 20s with low progesterone, young guys in their 20s, low testosterone. I don't know the cause necessarily, but I think it's environmental toxicity. So many factors that can cause your body not to produce it.
But the approach is the same? Either supplement or...
Well, no, the approach is not the same. I mean, the approach is to try to figure out the cause.
Right.
If it's central, if it's a brain problem, treat it in one way. If it's testicular, due to testicular damage, then you have to replace with testosterone. There's not much else you can do. But in younger people, generally, the testicles are fine. It's the brain that's the problem. And so you might treat them with Clomid. You might treat with HCG. Other options.
How do you control the level of testosterone? Because I know testosterone, high enough levels of testosterone in a woman is going to make her produce more hair than, or more male type hair pattern.
Mm-hmm. Well, we don't want to get a woman's levels that high.
Okay, so you have to reach a certain level in order for that to become a problem.
Right. Yeah. The normal range is probably generous. If you look at the typical labs, they'll go up to 45. But I think you can get up to even 100 before you start having problems. So the issue is really not seen in women on creams. You might see that more with pellets. So you have to be careful to check the blood levels and adjust the doses down, or you can get some hair growth. And then, some women who are just genetically predisposed to grow hair, especially Mediterranean, you just need to go to the clinic and have a laser. Because it's going to grow whether you take hormones or not.
Right,
but it's really going to be aggravated by testosterone. So you got to look at one of the things you tell women before you give them a testosterone product is you might have some more hair growth if the levels get too high. So, sort of electrolysis.
Which and I did send a client to have it done, and that's what we experienced, that she was getting more hair.
Right, well then she might have gotten too much, it's hard to know. Yes?
On that note, do you ever prescribe just the estrogen and progesterone without the testosterone?
Of course. Oh yeah, everything's individualized.
Okay.
I've had women getting only progesterone and estrogen because they don't need the testosterone.
Mm-hmm.
Sometimes only testosterone because they don't need the estrogen. Sometimes testosterone and progesterone. They still don't need the estrogen, but they're making estrogen out of their testosterone and want to balance the progesterone. So everybody's different.
Does it matter when you do the blood test? Does it matter when in your cycle you test it?
Yeah, we test at the end, 2 weeks of the end of the cycle. That's when the progesterone's highest.
And if you have no cycle anymore?
Well, then it doesn't matter.
It doesn't matter.
No.
Okay.
Okay, I think we got to call it quits. It's been a great time talking to you all.